8:05, tenemos, siendo las 8:05, buenas noches a todo Colombia, a nuestros amigos de Latinoamérica que se han juntado en este webinar de nuestra Asociación Colombiana de Artroscopia, ACCART. Hoy tenemos el placer y el honor de tener dos extraordinarios invitados, al doctor Gregory DiFelice, quien es profesor asistente del Hospital for Special Surgery, quizás la persona que más ha escrito en los últimos 15 años sobre reparación de ligamento cruzado anterior. Y tenemos también a una joven promesa colombiana de Medellín, a la doctora Carvajal, quien nos va a hacer una conferencia de qué está escrito en la evidencia en cuanto a reparación. So thank you so much, Dr. DiFelice, for being with us. We are delighted with your lecture. So everybody's ready to hear you. So take your time. So para todo el mundo, importante que abajo tenemos el símbolo de interpretación. Cuando el doctor DiFelice esté hablando, marcan español y el traductor que tenemos les traduce en español. ¿Ok? Así es de que, welcome. And
okay. Buenas noches. I hope that's right. I'd like to thank the ACCART team and Dr. Mosco for inviting me to give this lecture to you. I look forward to the time when I can make it to Colombia in person. My talk
Absolutely.
today is really twofold. First, I want to briefly share with you my technique and algorithm regarding ACL surgery, and share some of the lessons that I have learned over the past decade with arthroscopic ACL repair. My name is Greg DiFelice. I practice in New York City at the Hospital for Special Surgery. My practice is focused on sports traumatology. It's a trauma-heavy sports practice. I've been in practice about 22 years now. Some call me a surgical innovator due to my work with arthroscopic ACL repair, but I really don't feel that way. I'll tell you my story, and hopefully you may take away a few pearls, not about the technique, but about trusting your intuition and training. These are my disclosures company-wise, but I also want to disclose that I'm pretty biased in support.
we don't see your lecture, Gregory.
Oh boy, hang on. I'm sorry. I think I have you. Oh, what happened? It switched to you. Okay, I'm going to go back.
Okay.
Here we go. My bad.
Great. Okay.
Got that now?
Yes.
You didn't miss much. That was pretty much the start. 10 lessons learned in those 15 years. These are my disclosures, and I just like to say that I'm pretty biased in support of ACL repair because it works very well and it's fundamentally changed my practice life. But you guys can decide for yourself. Are we good?
Por favor, todos podemos poner los micrófonos en silencio.
Currently, knee ligament surgery is the largest percentage of my practice. And over the past decade, I've developed and adopted an approach to surgery I call the preservation first approach. It's a published treatment algorithm that's based on the tear type and tissue quality of the ACL remnant. It's focused on two basic principles: to preserve as much of the native anatomy as I can, and to provide for each patient the least morbid surgery that I can while still giving them a stable and functional knee. I focus on the tear type that can be seen on the preoperative MRIs to get an idea of what I will find at surgery. We've published a classification system modifying Sherman's to help surgeons to identify the tears that are most appropriate for repair. And I tend to focus on types 1 and 2 tears in the upper 25% of the ligament. In this paper, we looked at over 300 MRIs and defined the distributions of each type of tear. Amazingly, although most surgeons tell me that they never encounter repairable tears, we found that types 1 and 2 tears make up 40% of all the tears seen. Imagine if 40% of all tears could be repaired. I was taught a saying as a young surgeon, that is, the eye sees what the mind knows. I would suggest to you that when I look into the knee, I see things a lot differently than most of you. In this follow-up MRI study, we showed that when I focus on types 1 and 2 tears in the upper 25%, that I was able to repair the ligament in 94% of the time. My treatment algorithm is rather simple. I try to save whatever I can to give the patient a stable knee. If the tissue length and quality and the patient profile are good, then I will repair what I can. If the tissue quality and length aren't good enough for a repair, or the patient profile doesn't match, then I will repair what I can and add an augment graft if I need to, oftentimes a quadricep. And finally, I will only reconstruct the ligament if I have to. In other words, I use ACL reconstruction as my last resort, whereas the large majority of surgeons worldwide use reconstruction as their only resort. For the past 5 to 10 years or so, I repair at least 50% of my patients in my practice, and that includes probably over 80% of the patients over age 35. I augment about 25%, and I only reconstruct about 25% of my patients. Now remember, my numbers are skewed because patients seek me out for this approach. Understand that I didn't start this way. During my first 5 to 8 years in practice, I followed the standard all reconstruction approach. I began repairing the ligament in 2008, and I went very cautiously at first. I only repaired 20 people in the first 5 years, but as I became more confident with the technique and the results, I evolved to my current technique, and I'm happy that I did. Backed by my experience and published research, over 70 papers now, I know that my repair patients feel less pain, they recover faster, they have fewer complications, and they are less aware of their operative knee than those who have had reconstructions. I know that this is controversial and that I'm in the minority, but that's okay, because I have faith that you will all figure out sooner or later that not only does this measured approach make perfect sense to patients, but it works. After all, why in the world would you want to have a big surgery if you don't have to? Furthermore, why would I go to the bother of trying to convince you all that this procedure works well if it didn't? Trust me, it's not been fun trying to introduce a new procedure to the 30 other sports medicine doctors at the Hospital for Special Surgery and convince them of its merit. All right, let's get on to some more of the lessons we've learned. Lesson 1, trust your training and the body. The body will heal if given the chance. I trained at HSS with some of the giants in the field. Most important to me was Russ Warren. I learned innumerable lessons from him, and one that stuck to me was how to open repair the PCL in certain cases of severe multi-legs. And this planted the seed about ligament repair in my brain. The one thing that never sat well with me during my training was that when we went to do an ACL and the ligament looked fairly normal, like this one in a 15-year-old, which is a complete tear at the proximal aspect, invariably the surgeon would probe the ligament, pronounce that it was loose, at which point we would proceed with the reconstruction that never looked quite as good as that native ligament. The reality was that we were going to proceed no matter what, since we already had the graft in our hand. That's why I suggest that you always look in the knee before you start the case. This practice also primed me to move towards repair, since the body wants to heal. And when the tissues are minimally damaged and there's blood, there can be healing. And we know from studies like this one that the ACL has a more robust blood supply proximally. Lesson 2, be critical of history. Study history, but be critical of it. Although it is comforting to think that the evolution of surgical thought is based on hard scientific research and discoveries, in reality, as most of us know, most of it is trial and error. Although the standards of our research are improving, we have to be critical not only of our current research, but the historic research too. If early conclusions are wrong, then the house will be built on a poor foundation. Unfortunately, it seems that few of us have time to spend thinking about this. To synopsize the first 20 years of ACL surgery, we can sum it up with great idea, bad execution. And yet many foundational conclusions about ACL surgery came from this early experience. Both the early tenodeses and the open primary repairs and then augmentations were doomed to failure by the maximally morbid open approaches, followed by casting, with the resultant stiffness and loss of range of motion that led to severe patellofemoral symptoms. I recently performed a total knee on this patient who had an open multi-lig 30 years prior. He told me that he was in a cast for 9 months. I honestly believe that the move away from casting and to early motion was probably the biggest breakthrough in all of ACL surgery. Specific to ACL repair, it was also the one-size-fits-all approach of repairing all types of tears that doomed the results. Amazingly, even with the treatment is worse than the problem approach, 60% of the people ended up with stable knees. I'm not sure exactly how the dogmatic conclusion that the ACL can't heal was derived from this experience, since over half of them did heal. To investigate this theory, my group looked at the outcomes of all ACL repair studies that were published for 50 years. We stratified the groups by those that had a mixed tear type and those that were all proximal. And we found that the proximal group in red had statistically better outcomes in every measurable subjective and objective category. This shows that even with the old barbaric surgery, patients still did reasonably well when the tear was proximal and amenable to repair. We simply drew the wrong conclusion, which drastically altered the evolution of surgical thought. Lesson 3, necessity is the mother of invention. I quickly learned this when I started in practice at a level 1 trauma center in the Bronx. And we as orthosurgeons, and I would say arthroscopists even more so, are a very creative and innovative bunch. Heck, the fact that we can even perform effective arthroscopy is a testament to our surgical predecessors and societies like ACCART that defined the field and fought the battles against the status quo to establish arthroscopy as a legitimate technique. Since I was the only sports medicine trained surgeon at this level 1 trauma center, I found myself inundated with complex multi-ligs like this open dislocation, which I call the mother of all dislocations. If you look closely at the tissue on the shin there, that's actually the center slip of the quadriceps tendon that avulsed from the AIIS from the hip and flipped out onto the front of his leg, because you can see there that it attaches to the patella. I've never seen that before, and I've never seen that since. And by the way, I've shown this picture to no less than 5,000 to 10,000 orthopedic surgeons, and no one has ever guessed what it was. We strung this guy's knee back together, trying to minimize the infectious risk by only using suture. And you can see him from this 1-year post-op video that he's doing pretty well. When you decrease the morbidity of the surgery, then the patient population can achieve better outcomes in all environments. The key to the puzzle was back in the early 2000s when the rotator cuff instrumentation was starting to come along. It allows us to reach in through arthroscopic portals and do amazing things that we all know about nowadays, but back then were unheard of. It allowed me to drastically reduce the morbidity of the surgery and provide excellent fixation with suture anchors right at the wall, rather than suspensory fixation with buttons. The anchor fixation is an intrinsically better approach, in my opinion, because aperture fixation beats suspensory fixation for primary healing. It may be different for hanging a graft, but for primary healing, it's my opinion that aperture fixation is the best. Back then, I was getting pretty good at arthroscopic cuff repairs at the time, and my feeling was that if I just closed one eye and rotated it 90 degrees, that the rotator cuff looked like an ACL. And we all know, as a collective orthopedic community, we have no hesitation putting the rotator cuff back to bleeding bone, knowing it will heal. Now shift to the knee. It's really not that significantly different. The argument that was accepted to explain why the ACL is different and can't heal is because the blood clot will not hold in between the ends of the ligament. However, this argument becomes moot when we focus our repair efforts on proximal tears, because the blood clot holds nicely between the ligament and the bone, especially when the repair sutures tend to anchor it. Let's be realistic and academically honest with ourselves. Everywhere that we put soft tissue next to bleeding bone in the body, it heals readily. So why should the ACL be any different? The answer is that it isn't any different. The blood clot theory, and it is just that, a theory, is a seductive narrative that may apply to mid-substance tears, but is less likely to apply to proximal or distal tears. Not only did the rotator cuff repair technology allow me to stitch the ligament through the portals, but allowed me to create a strong repair that allowed immediate weight bearing and motion. And that is, in all honesty, how it came about. Cherry-pick the proximal and distal tears that are likely to heal to minimize failures, perform a sound repair arthroscopically to eliminate the morbidity, and finally allow early motion to solve the stiffness problems that came from casting, and you have selective arthroscopic ACL primary repair. Trust me, it will not only change your patients' lives, but your practice life will become much more pleasant because your ACL patients will suffer less, recover faster, and their knees will feel more normal. I have done over 500 ACL primary repairs, closer to 600 if you include the multi-legs. And the question that has to cross your mind is, would I be really going all over the world talking about this if it didn't work? Lesson 4, scope the knee first. Enough said. This is an obvious one. You are never going to repair the ACL if you take the graft first and then look in the knee. You will always convince yourself that the ligament is loose and it needs to come out. So when you look at one like this and nausea sweeps over you because you have the graft in your hand, you'll never do that again if you start to look before you take the graft. And I strongly, strongly urge you to do that. Lesson 5, indicate patients appropriately. So we have a number of outcomes papers out there, and we've found that ACL repair can achieve both short-term clinical success and midterm success in a carefully selected subset of patients with proximal avulsion tears and excellent tissue quality. Good to excellent, actually. Multiple papers out there. We've got multiple outcomes papers. I suggest that you look them up. I don't have time to go through them, obviously, but we really do have nice outcomes. I have found that using my technique, roughly 1% of patients over age 21 will fail each year. So roughly 5% failure rate at 5 years and 10% at 10 years. That's kind of what I've seen. It's different for the under 21 crowd, where it's a higher failure rate, which is why I've limited the amount of times that I operate with a straight repair on that group. This recent systematic review showed that these numbers are pretty true for all different types of repairs out there. And again, it confirms that the under 21 crowd, under 21-year-old crowd, has at least a 5-fold increase in risk of failure if you're doing a straight repair, especially if they do level 1 cutting sports. However, the over 21 crowd does quite nicely. Lesson 6, educate yourself. This article came out recently documenting the dramatic surge of interest in ACL primary repair over the last decade and across the world. It also documented HSS as the most prolific institution in writing about repair, and showed that my research group, along with Dr. Murray's, were the most prolific groups writing about the topic. So the point is that there's a burgeoning body of research out there that you can learn from. And there's been several prospective randomized comparisons of repair versus reconstruction in the past year and a half that have shown pretty much equal outcomes, except a much easier recovery for the repair patients. In addition, you can educate yourself by availing yourself to technique videos. This is a recent updated technique video in arthroscopy techniques that we released. You can scan that QR code and get right to the article, and it shows you exactly how I do it with video instruction. And there's multiple different videos out there in the academic world. If you go to the industry world, you can see a lot of videos on the Arthrex website. Here's one of mine. And then there's also multiple other techniques that have popped up that Arthrex has sponsored, including the fiber ring and tightrope technique, in addition, the button technique with the internal brace, and several others. And I suggest that you look at the Arthrex website. It's a tremendous resource for learning different ways of doing this. Lesson 7, practice the steps. So here's a picture of me at one of my at the grand rounds that I've recently given at the University of Toronto and the University of Tennessee. And it's a great way, learning in the laboratory, to practice and get the feeling for how to repair an ACL. It's very simple to slice it off the wall, and then you can practice the steps necessary to learn how to do it. I also suggest that in addition to the cadavers, one of the things that you can do is to practice stitching the ligament when you're doing a reconstruction before you take the ligament out. So you can stitch the ligament and then remove the ligament so that you can practice the steps of the repair procedure and use them at a later date. Lesson 8, internally brace the ACL. This is the only modification that I have added to my procedure in the 15 years that I've done it. I started off and I would selectively repair it or add the brace depending on how the tissue looked. And then I started to add the brace for everyone. And there's more than enough data out there that shows that the brace is a good addition. We just completed a prospective study because many people argued with me saying that we're only relying on the brace and not the ACL repair. In reality, we used lock meter studies where we took the lock meter into the operating room and we took pre-repair, post-repair, and post-internal brace measurements. And you can see here from these diagrams from the paper that the first boxes are showing the anterior tibial translation before the repair. The second box is after the repair, but before the ACL, the internal brace was placed. And then you can see after the internal brace was placed, there's no difference in the translation. So what that's showing is that the internal brace is not over constraining the knee, and it's not stress shielding things. That is in submission for publication. Close to done now. Last one I want to say is lesson 9 is trust your patients with the milestone-based rehab. what you'll find is that the patients recover incredibly quickly. It'll make you sick to your stomach because you think that you have to go slowly. But when you avoid all the morbidity of the big procedure, they don't lose their quad, they keep their proprioception, and they can really protect themselves. And I want to show you a brief video, less than a minute long, of one of my patients. He's a 34-year-old former college football player who tore his ACL playing basketball. It was a type 2 tear, and we repaired it. We had medial and lateral meniscus repairs, and you can watch him recover right here. It's truly amazing. He sent this video to me, and you can see there's the repair. He set it to music. The first month and a half, he was on crutches because he had those meniscus repairs, but you can see how quickly he just rockets ahead of everyone. So this is at 2 months post-op. He's doing a 12-inch box jump, one-legged, and then he quickly goes to a 36-inch box jump. This is 3 months post-op. And I would argue with you that no ACL reconstruction patient has ever looked like this in the history of the world. I would love to hear somebody's secrets to show me how they can get this outcome. He's now close to 2 years out. He's been playing basketball for a year and a half, and truly amazing recovery. Lesson 10, the last one, is collaboration is the key to success. When I started doing this stuff 15 years ago, I was all by my lonesome. And then I went out to try and tell everyone how I thought it would work and how I was excited that maybe there's a new breakthrough. And I was completely attacked and assassinated. That still persists to this day. It's amazing. But what I've found as the years go by is more and more people are starting to open their minds to maybe this is a reasonable idea. And actually, you know what? It kind of makes sense. And all of the people you see here pictured are people who've collaborated with me, who've done great work and have started to put out their own research. When I gave my first talk in 2012, I said to everyone that I wasn't here to tell them what was right and wrong. I simply wanted to start a conversation. And that's what's going on now. As I'm talking here in Colombia and all over the world, I've given this talk and people are starting to realize that, hey, maybe that guy's not so crazy. Maybe he's got a point there. And hopefully one of you will come up with a better way of doing it. I'm not saying my way is the only way. Last but not least, I'd like to thank my research group. Over 70 publications, and it's only these 8 people who've assisted me in that. It's been truly amazing. I was never a research guy. I was never good at it. And yet here I find myself a researcher, and it's been great. We actually started a research foundation to support the project. And with that, I'd like to thank you all for your attention. You know, if you're interested in this stuff, feel free to contact me. Feel free to fly up to New York City and watch me do it. I think that's one of the greatest ways you can learn, and you can actually wiggle the knees yourself and see me do it live. And then if you can follow me on Instagram at Dr. DiFelice, or you can follow the foundation, DiFelice Foundation. And hopefully you can join the ranks of people who have been enlightened as to how this stuff really works. So thanks for your time. I'll turn it over. I'm sorry for running a few minutes late.
Thank you so much, Dr. DiFelice, for this extraordinary lecture. And next is Carolina Carvajal, quien nos va a hacer un resumen de la evidencia. Y después vamos a tener 30 minutos de preguntas, de discusión. Carolina.
Bueno, buenas noches para todos. Voy a compartir mi pantalla. Agradecer a la ACCART y muy especialmente al doctor Mosquera por esta invitación para compartir hoy con ustedes, que pues claramente para mí es un honor, sobre todo porque mucho de lo que revise está escrito por el doctor DiFelice, que nos acaba de compartir muy generosamente su experiencia. Entonces vamos a hablar de lo que hay de evidencia sobre reparación del ligamento cruzado. Yo soy Carolina Carvajal, estoy en la ciudad de Medellín. La línea de tiempo para las lesiones de ligamento cruzado anterior es muy extensa, es de décadas. Históricamente, pues siempre en la cirugía deportiva, en la cirugía de rodilla, se ha pensado la mejor manera de solucionarle a estos pacientes los problemas. Lo que sí es claro es que en medicina en general, los procedimientos que han caído en desgracia en el pasado, con el tiempo vuelven a ser tendencia. Y cuando son tendencia, muchas veces se hace más énfasis en los beneficios que en los riesgos de estas nuevas opciones y se suelen manejar pacientes con poca evidencia. También es cierto que los avances en los implantes y en las técnicas quirúrgicas ayudan a perfeccionar las técnicas, a mejorar los resultados de cualquiera que sea el tratamiento, que el marketing tiene un papel fundamental, tanto apoyando los sesgos en los estudios como apoyando económicamente el avance de estos implantes y técnicas, y que es necesario desafiar los dogmas históricos para poder avanzar en el manejo de nuestros pacientes. Entonces, el tratamiento del LCA roto de 1895 y durante los primeros 100 años fue con cirugía y fue reparación, que es lo que nos tiene hoy acá. En 1895, Mayo Robson publicó una reparación primaria de cruzado anterior y posterior de lesiones femorales que suturó con Catwood. Entre 1938 y 1955, varios autores, tal vez estos los más reconocidos, publicaron reparaciones primarias abiertas del ligamento cruzado anterior y referían que la técnica y los resultados eran esperanzadores. Sin embargo, al pasar los años, en 1976, el doctor Fegin, que fue uno de los que había publicado mucho de su casuística, reportó cómo 5 años después de operados estos pacientes tenían muy malos desenlaces en la reparación, con un 94% de inestabilidad y 71% de dolor. Y así ya fueron saliendo los artículos que decían que tal vez la reparación no era tan buena. En este se citan varios autores en 1986 diciendo que a pesar de que en los inicios fue prometedor, persistían con dolor, con inestabilidad, con limitación funcional, y esto fue llevando paulatinamente a la reconstrucción, que como sabemos primero fue abierta, actualmente artroscópica, y a hoy sigue siendo el estándar de oro para el manejo de las lesiones del ligamento cruzado anterior. Pero ¿por qué si la reconstrucción es el gol estándar, estamos buscando otras opciones? ¿Será que tampoco es tan buena? Pues la tasa de fracaso es el 15%, que es alta. Al momento de la revisión, el 90% de los pacientes reconstruidos tienen lesiones condrales o meniscales asociadas. Pueden revisarse alrededor del 38%, y eso que muchos son sintomáticos y no se revisan. Y el retorno deportivo, que es lo que finalmente nuestros pacientes están buscando, está muy por debajo de lo esperado. ¿Será entonces la reparación la solución a este problema? Lo primero es preguntarnos si el ligamento cruzado anterior cicatriza. Varios de los autores que cito ahí, incluido el doctor DiFelice, ya nos lo contó. No es cierto que el LCA no pueda cicatrizar. No todos los desgarros, sino solo algunos, tienen capacidad de cicatrización. El doctor Guyen reportó un estudio histológico donde el tercio proximal del ligamento cruzado anterior tenía una respuesta de cicatrización similar al ligamento colateral medial por unas características histológicas muy similares. Esto fue en 2014. Y en 2007 ya el doctor Matías Costapans había reportado cómo en resonancia magnética es posible ver cambios de cicatrización del cruzado. Él reportó 7 pacientes que fueron programados para reconstrucción de cruzado, que por diversas causas no se pudieron hacer, y al año repitieron la resonancia, encontrando en 6 de ellos un ligamento continuo de punta a punta con señal homogénea. ¿Cómo se repara? Se puede hacer con suturas, borde a borde. Se puede además adicionar un anclaje a la pared femoral, que es de donde se desinserta con más frecuencia para que pueda ser reparado, y ya lo vamos a mirar. Y para mejorar la estabilidad de esta reparación, se inventó la aumentación con cinta con un internal brace. Eso favorece la cicatrización y además de mejorar estabilidad, para mejorar biología, que ha sido otro de los problemas, existe el VER, que es un andamio extracelular que busca agregar un coágulo en el lugar de la ruptura para mejorar la cicatrización. Estas son las opciones más frecuentemente descritas en la literatura. Hay otras de estudios más pequeñitos que no tienen tanto eco por ahora ni tanta evidencia. ¿Cuáles son las ventajas de la reparación? Pues que se preserva el tejido nativo, Hay menos morbilidad, incluido el sitio donante del cruzado. Se conserva la propiocepción de la rodilla, la recuperación es más fácil, menos dolor, más movilidad. En caso de que haya que hacer una cirugía de revisión, hay menos problemas, por lo que conocemos todo de los túneles y los implantes. El procedimiento puede ser más corto, se infecta menos y tiene menos riesgo de lesión fisiaria. Entonces habría una ventaja potencial también en los pacientes con fisis abiertas. La clave en general en la literatura coinciden en la selección del paciente. Estas son las 5 características que encontré con más peso. Sitio de la lesión, calidad del tejido, tal vez son las más importantes que ya el doctor DiFelice nos las explicó. Tiempo de evolución, edad y lesiones asociadas pueden ser otras que ya vamos a comentar. Entonces, respecto al sitio de la lesión, el doctor Sherman en 1991 nos mostró una clasificación donde actualmente sigue siendo la más usada. La tipo 1 es una avulsión proximal del LCA, la tipo 2 es con un muñón de menos de 20% femoral, 3 y 4 son en el tercio medio con un 33% de muñón y en la sustancia media. En general, los Sherman 1 y 2, el 1 más que el 2, son los que mejor responden a la reparación. Para 2020, Vermeyen, el doctor DiFelice y otros coautores expusieron este artículo donde hablan de porcentajes. Entonces, como vemos en la imagen, lo que hay que calcular es el porcentaje del remanente tibial del ligamento cruzado anterior, que aquí está pintado como en naranja, y en este lo vemos un poco más cortico. Si el remanente es mayor al 80%, mejoran las probabilidades de que le vaya bien con la reparación. Si es menor al 60%, probablemente requiera una reconstrucción. Entonces ellos dicen que la longitud del remanente se puede medir de forma fiable en la resonancia y predice la reparación. Así las cosas, incluyeron 248 pacientes en este artículo que está citado abajo, con diferentes ubicaciones de desgarro, en los cuales repararon los que tienen más del 80% del remanente distal del LCA. Estos son imágenes de artículo, donde el sitio de la lesión juega un papel fundamental. Como ven en esta resonancia de un corte sagital T1 y T2, algunos de ustedes probablemente en el auditorio pensarán, es un ligamento más o menos bueno, ni siquiera es quirúrgico. Acá vemos una lesión proximal del ligamento cruzado anterior. Estas son las imágenes artroscópicas y los autores describen que acá el remanente es muy largo, que acá la calidad es muy buena de tejido para la artroscopia, que es un buen candidato para la reparación, lo reparan con buenos resultados. Y este es otro bien diferente, donde la ruptura es un poquito más distal, un poquito más completa, donde en la artroscopia también la calidad del tejido no es tan buena, pero en general describen que la avulsión es proximal, que la calidad del tejido es buena, y le realizaron para ese momento una reparación primaria sin internal brace, reportan buenos resultados. Respecto a la calidad del tejido, es tenido en cuenta en resonancia y en artroscopia. En resonancia en general, la literatura describe una señal oscura, homogénea, de las fibras del LCA que discurren en la misma dirección en T2 de resonancia. En la artroscopia es más subjetivo, hay que tener en cuenta la apariencia y la consistencia, que la lesión sea parcial o que sea una rotura limpia, no les va tan bien si los desgarros son múltiples y que tenga buena vascularización. Básicamente, que los remanentes puedan soportar la tensión de la sutura y la reparación. Respecto al tiempo de evolución, en general los artículos reportan que agudo, idealmente en las primeras 6 a 8 semanas o en menos de 3 meses. Este no tiene tanto peso como la calidad del tejido y el sitio de la lesión. Inclusive en este artículo retrospectivo de 69 pacientes, incluyeron la mitad que repararon agudo, la mitad que repararon tardío, es decir, más de 3 meses después de lesionados, los siguieron a 2 años y los resultados son muy similares. Reincidencia 9 versus 11%, las tasas de reintervención, complicaciones y lesiones de la otra rodilla fueron muy similares y los resultados fueron también comparables. Entonces, si bien el tiempo de evolución está descrito en la literatura como un factor que puede mejorar los resultados en reparación, es un poco débil porque a los que han reparado tardíamente también les ha ido bien. En cuanto a la edad, en general están de acuerdo que le va mejor a un paciente joven, teniendo en cuenta que el envejecimiento pues disminuye la calidad del tejido, la capacidad de cicatrización y puede disminuir el éxito, y que con el envejecimiento aumentan las lesiones adicionales que pueden hacer que la reparación no sea la opción más adecuada. si bien estos pacientes jóvenes se pueden reparar con, digamos, una buena confiabilidad de que la reparación le puede ir bien, también tienen más tasas de falla, como hemos visto, igual que en los pacientes que se reconstruye el ligamento cruzado anterior. Y el quinto son las lesiones asociadas. En este artículo describen que la membrana sinovial tiene un papel fundamental para la reparación. Entonces, reparten los pacientes en grupos A, B y C. En el grupo A, como ven la imagen, son pacientes que tienen membrana sinovial intacta, donde el ligamento cruzado anterior está roto solo en un segmento desprendido de proximal. En el grupo B están los pacientes con desgarro de la membrana sinovial, donde se logran ver 2 cabos del ligamento cruzado anterior, y en el grupo C es un desgarro de la membrana sinovial con rupturas múltiples de LCA. Estos autores reportan que la ruptura de la vaina sinovial es un factor independiente para el fracaso de la reparación y que la lesión del LCA con disrupción de la membrana sinovial aumenta el riesgo de falla de la reparación del mismo. Por tanto, proponen que debe ser reparado sobre todo en los que tienen membrana sinovial intacta y una ruptura nítida del ligamento cruzado anterior. También hay otros puntos de vista. Hay una serie de casos con muchos pacientes con un nivel de evidencia 2, donde incluyen población militar activa, 46, que repararon entre 2017 y 2019 y les hicieron 2 años de seguimiento. Esta es la tabla de factores demográficos. En general son pacientes jóvenes, la mayoría hombres. Los clasifican según índice de masa corporal, nivel de competición, si fuman o no. Les realizaron a todos reparación más aumentación con una cincha. Ellos describen como criterios de inclusión que en la artroscopia tengan una avulsión proximal con tejido remanente adecuado. Y reportan descrito como fracaso que tenga una nueva ruptura o una inestabilidad clínica que requiere revisión, la falla del 26% de estas personas. Fallaron más los de 17 y 35 años que tenían un nivel de competencia élite y que además fueran fumadores. Estos autores concluyen en 2023 que la reparación artroscópica primaria del LCA con aumento con una cinta resultó en tasa de fracaso inaceptablemente altas en mínimo de 2 años de seguimiento en una población militar muy activa. Esa es como la otra cara de la moneda. Respecto a los grados de recomendación, el JBJS publica esta revisión donde incluyen 1.106 rodillas, artículos retrospectivos, prospectivos de varios autores de muchos años muy variables, y lo que concluyen respecto a la evidencia es que la reconstrucción del LCA sigue teniendo una evidencia tipo A, pero que el grado de recomendación para reparación, ya sea con solo sutura, con sutura de anclaje, con brace y con BER, todavía es insuficiente o es no concluyente para recomendarla abiertamente como el tratamiento ideal. Entonces, las conclusiones que para el momento todavía no se concluyen porque es un tema que está en discusión es que los resultados son prometedores con el avance de los implantes, la técnica quirúrgica y el conocimiento del potencial de cicatrización y de la biomecánica del LCA, que tal vez la clave es la selección adecuada del paciente, porque en los estudios que pues meten muchos pacientes a reparación, probablemente los resultados no son tan buenos porque la selección no fue adecuada, que falta evidencia para probar las ventajas sobre la reconstrucción y también falta la prueba del tiempo. Muchas gracias.
Gracias, Carolina, por tu extraordinaria conferencia. Entonces vamos a dar paso a la sesión de discusión y preguntas. Tenemos varias preguntas, Sebastián. Primero darle paso a la audiencia antes de que cada uno de nosotros pregunte.
Entonces, pues voy a compartirle al doctor DiFelice las preguntas que se hicieron en el chat.
Ajá.
Ahora podrías dejar de compartir tu pantalla, por favor. Okay, so
Listo.
Dr. DiFelice, do you hear us? Are you hearing us okay? Yes, okay. So we have a question from Dr. Ginás from Cali. He's asking what role does clasping have in the inability to heal of the torn LCA? And does it, if it has any role in the repaired ACL?
I would imagine that the reference to plasmin is probably referring to PRP or some of the those types of substances. There hasn't been any studies looking at augmenting the repairs with the biologics that I'm aware of. In my opinion, putting the anchor into the wall, which is vented and allows the BMPs to come out, that is enough rather than augmenting it with concentrated platelets. I'm not aware of any data looking at that. A comment that I would also like to make in regards to Carolina's, Dr. Carvajal, I hope.
Yeah,
Yes.
that's
That
right. Carvajal.
in her talk, which was excellent, is that one of the troubles with looking at ACL repair research is that there's a number of different techniques. Many of the systematic reviews lump all of the techniques together. The one in particular that she looked at, the current concepts in the JBJS article, was actually written at my institution. And they included research from back in the 90s, which poisons the data because they're including outcomes from the old open procedures. In addition, they don't differentiate the outcomes based upon how it's done. And that we have a systematic review with meta-analysis that we're going to be publishing in the next year or so that breaks it down based upon the type of procedure done and how that's looking. And it's interesting. What I can tell you is that I'm not so sure it matters how you repair the ACL as long as you pick good tears to operate on. But the one thing that's clear amongst all the data across all the techniques is that if you try to use ACL repair as an isolated approach in patients who are under 21, you're going to have probably a third of the patients fail. That's what my study showed, is roughly a third of the patients failed. But one of my studies that's going to be published soon is the 8-year follow-up on that same group. And after those that 1/3 failed, no one else failed. So 2/3 of the patients under 21 have good outcomes out to 8 years. So maybe it's just a selection criteria. Maybe we have to add an LET to a primary repair to protect those younger people. I'm not exactly sure what the right answer is. All I know is that if you guys down there in South America are going to start doing ACL primary repair, I would strongly suggest that you start off in the group over age 35 that tore it skiing on vacation with the family. If you do that, you're going to have great results. Now, we can argue a lot about whether that group needs surgery or doesn't need surgery. That's a whole nother conversation. But it's a very different conversation if you're talking about do nothing or have a huge surgery, and then you replace have a huge surgery with have a really small surgery. Then you might decide, you know what, it's worth it to give myself a stable knee when the recovery is so quick. So there's a lot of the literature out there that I didn't write that comes from the other camps that are very, very, very biased against ACL repair. They don't really get the argument, and it's frustrating. It's very frustrating. For example, AJSM. So far, my group has published over 70 articles in the ligament repair space. We have not had a single article accepted to the AJSM. Actually, excuse me, we had one article that wasn't about repair. It was about like the failures of recon. But literally, they have rejected every single paper we've ever submitted. And to me, that's biased in the other direction. And look, if anybody knows, it's me, because I spent the last 15 years fighting up this hill. And so it's nice to have some people with me, because it's been a lonely battle. So it's a long-winded answer.
Excelente.
We have a question. I'm gonna mix a lot of questions to just make you one of them, or like to concise it in one. There's a question about how long after injury do you repair? How long do you augment it? And how long after injury do you reconstruct? There's another question.
Okay.
Yeah.
Let me
There's
answer
another-
that one quick.
Yeah, okay.
All right. In
Go
the
ahead.
beginning, I thought I had to do it within 3 weeks. But then I had a patient show up who was 6 months later, who couldn't get approval. And they had an absolutely perfect tear that was right against the wall. In fact, that patient was my nephew, who didn't have insurance, who needed surgery, and they couldn't afford it. So I repaired him. He was back playing rugby in 4 months, and it's 13 years later, and he's never had a problem. He was 20 years old at the time. And I had another patient show up who was 11 years after his injury, 11. And we actually published this paper. And he came in with a bucket handle meniscus tear and said, "Doc, I can't straighten my knee." And I said, "Oh, you have a bucket handle tear." I said, "But your ACL is loose." And he said, "I tore that 11 years ago, but I was a young father and I didn't have time to take off from work. I had just bought my house and I was scared about the recovery." It turns out that his ACL scarred to his PCL. And when I looked inside of his knee and fixed the meniscus, we simply clipped the ACL off the PCL and reattached it to the wall. And he's now 11 years out from surgery, and he's been playing all the cutting sports that he never could play since that time. And it's this experience over 15 years where I've learned from my patients. I've also learned how to trust my patients are going to be okay when they start running at 6 weeks, because a bunch of patients came in and said, "I just ran 3 miles in the park at 6 weeks." And I was going like this. And they were like, "Doc, I feel fine. You're great. My knee's awesome." And you start to learn and you start to believe. So what we found is that it's not a matter of, put it this way, if you repair people within 6 weeks or 4 weeks, you'll be able to repair more of them. But that doesn't mean you can't repair them after 4 weeks. I've repaired a patient 30 years after his ACL was torn. 30 years. Okay, so it all depends on the tissue quality, the length, and whether it will reach the wall. And so, that's been my experience. And I have well over 100 patients who I've repaired over 6 months out, and randomly up to 30 years.
Okay. There's another question about, you're talking about a lot about returning to sports really fast. So do you have any protocol for the rehab for these patients you reattach?
So I use what's called a milestone-based recovery. And what that does is, rather than basing it on time, like you have to wait 6 weeks in order to do this, and then you have to wait 3 months in order to do that, is I base it on how quickly they recover. In other words, for example, one of the first milestones is whether you can unlock the brace when you walk. And if my patients can do a straight leg raise 25 times without a lag, then I'll allow them to unlock the brace now and walk around normally. Now, for many of my patients, that happens within the first week. And that scares doctors. And it used to scare me, but it doesn't scare me anymore, because when you don't do the big surgery, they keep their quadriceps control and they can safely walk. And when their knee feels normal, because they still have their ACL and they have the proprioception, they can protect themselves when they walk. One of the critical things that I would suggest to you, if you are going to do this, and if you do ACL reconstructions, is I see all of my patients within 5 days after surgery, and I drain the blood. I aspirate the blood out of their knee. What that does is allows them to get their range of motion back, and it allows the quadriceps to fire. And I strongly, strongly encourage you to start doing that. That will change your experience with ACL patients. You avoid the tremendous atrophy that you get in the quadriceps. You get your range of motion back faster. And most importantly, your patients won't struggle as much. So see your patients early and drain the knees sterilely. And that's a big help. I do that for everyone.
Okay, you were talking about all these biologic advantages of repairing the ACL. Why do you do so much internal bracing now? If you have all these biologic advantages, you don't have quadriceps atrophy because of the fusion. You have a lot of things that are really good for the knee. Why do you think it's necessary to internal brace it? To
Well,
do an internal brace nowadays?
I still think that you're healing tissue, and the internal brace, as I've found, it adds strength, but it doesn't add a lot of downside. I've been working extensively with a company called M-Body, and what we've done is we've created a series of sutures and tapes that are half collagen, right? And I think that's going to be a game changer, because now we can do an ACL repair with collagen tape, right? And so it will grow right into it, and it will give you the biologic advantage that we don't have currently with the synthetic suture material. So we'll see. That's going to be coming out pretty soon. Zimmer actually bought the company M-Body, and so they're going to be marketing that product. It's called Active Braid, and it's I'm very excited about that because we've been working on it for about 4 years now.
Okay. There's another question, a really good one. That's do you have any experience with the APS or MCS augmentation at the same time or after surgery? Would you think it could be a good option for the patient to improve their outcomes?
Do I have
APS?
What's this?
With, I think that's gonna be
Mesenchymal cells, probably.
mesenchymal cells. Yes.
With the
scaffold,
cell therapies?
with scaffolds, PRP, mesenchymal cells.
I haven't done any of that, and it hasn't really affected my outcomes. I think that the body wants to heal, and if the tissue gets close to the bone, it's going to heal. And I don't believe that you really have to do that stuff. As far as trying to get the ACL to heal just by injecting the biologics, there's a number of people who will talk about that. And the trouble is many of the times I feel that it might be a partial tear. It might be something that's reasonably stable on its own, and it was going to heal by itself. And then they inject and say that the PRP saved the day. But they're really, I'm not aware of any studies. I've seen a few case reports, and look, if you could inject a magic sauce in there and make it heal, look, we'd all be happy, man. We could all go to the beach and have a good time and not spend so much time fixing these things. But I haven't seen any impressive evidence that it really works.
Are you using any extraarticular augmentation now? Or do you have any indication for that?
I don't use the LET or the lateral side augmentation on my patients who are over 21. I don't think you really need it. Let's put it this way. If I start doing I think I might start a study on the under 21 crowd, looking at repair with LET, because I think that might be able to decrease the failure rate from 1/3 down to 15%. And then it's probably even with reconstruction, except without the morbidity.
Okay. Mosquera,
There's a
Yes.
recent paper out by Ferretti and Monaco from Italy, looking at ACL repair with LET compared to reconstruction. It just came out within the last month, and it shows pretty much equivalent results. So that's a very promising technique.
Gregory, you mentioned that probably in your experience, in your practice, you do 40% ACL repair. So that's mean
50.
50%. Okay. So I thought I was crazy because my percentage is a little bit less, but when you read the paper, everybody say that it's not more than 50%. So that the question is, that's mean if one surgeon do 100 surgery, ACL surgery, and he does 95% ACL reconstruction, he's overestimated the reconstruction. It's the same with the uni in arthritis.
Sure.
Does it true?
Well, look, I didn't start off doing 50%. I started off doing 2%, right? You know, and it took me, in my first 5 years in practice, I only did 20 patients, right? And now I do over 100 a year. So it took me a long time to go up the ladder. Now, hopefully for some other, like nowadays, you can pick up these techniques a lot quicker than when I was figuring it out myself. And you can gain confidence by listening to my talks because I already lived it, right? So most people starting off are back where I was 10 years ago. And that's okay. You got to start somewhere. You know, that's like the people who are the naysayers, right? The people who are biased against repair. They always say, like the one article Carolina quoted, that there's no A-level evidence for repair. And my answer to them is, well, why don't we roll back to 1994 and tell me how much A evidence there was for reconstruction in 1994? But that didn't stop us from doing it. In fact, we did it on everybody who walked in. So I think that as orthopedic surgeons, we're hypocrites, right? The people who do the technique that's tried and true are very fast to attack the people who try something new. Whereas if we just rewind the tape 20 years, they were once the people who was trying something new and being attacked by the older guys. And it just goes in cycles. And that's the thing that kills me, is that it doesn't make any sense, right? I mean, let's be realistic. To have one surgery to treat every single type of ACL injury, even a partial tear that's not even completely torn. Are you kidding me? You couldn't pay me to have my child. If he had a partial tear, you couldn't pay me to have him have a reconstruction. Why would I? I can repair his ACL, and even if only 50% of them heal, that means 50% of them avoided the morbidity of a reconstruction, which, as we all know, is rather morbid. I wouldn't put my hand up and say, oh, I'd like to have a reconstruction tomorrow. Hey, why don't you take my patella tendon and put it right up there in my knee? Because I really want to get that one. No way. We all have seen the patients who don't do well. And I'll show you one picture, and this says it all. My patient was a collegiate athlete. She tore her ACL playing lacrosse, and she had a quadriceps reconstruction. It took her an entire year to go back. Within 3 months, like so many people do, she played again and she tore her other knee. Right. And she was just like, oh my gosh, we all have patients like that. It breaks my heart. It honestly breaks my heart. Anyways, it turns out her other knee was a partial tear. Now, a lot of us are faced with the dilemma of, do you do a reconstruction or do you just wait and see if it becomes a complete tear? Well, with the ACL repair, you have the option of trying to heal it. This is my patient 3 days after ACL repair. Tell me, how many patients have you ever had that are smiling 3 days after ACL reconstruction? All right. Now, I know these little examples are silly and people are like, oh, you shouldn't do that. It's unprofessional. But if you never see what I see in my office, you're never going to believe. That's why I encourage people to come up and to spend some time with me and see my patients and listen to their stories and wiggle their knees and watch me do the surgery. And maybe then you'll say, well, you know what? That guy's not as crazy as I thought he was. I believe the word is loco in Spanish.
That's the word.
There
That's
you
what we
go.
use in Mosquera. That's the word we use with him.
That's
There's a lot of questions about the pediatric population. Do you think the repair is the indicated way to go with these little guys?
It's interesting with the little ones, right? Now, if my 10-year-old or 11-year-old or 12-year-old had an ACL tear, I would consider repairing it to just see if it heals. Let's be realistic. Do you want your 10-year-old or 12-year-old to go through a major reconstruction, an over the top or an all epiphyseal reconstruction? Not just because of, whether it's going to affect the growth plate, but because that little one is going to be scarred mentally by the experience. I mean, let's be realistic. Half of our adult patients have a hard time getting through reconstruction, let alone a 10-year-old. I mean, we kid ourselves when we say, oh, they're good athletes. No, they're not. They're children. And so in my opinion, if you repaired 10-year-olds and 12-year-olds and they had a good tear and you could do it under the growth plate, and let's say you had 50% of them heal and 50% of them went on to have a reconstruction. Well, in my world, in my life, to me, that's a win. If you saved 50% of children from having to have a reconstruction, that's a huge win. And the other thing is, I just had a patient, actually, I'm seeing her tomorrow. She was 12 years old, wide open growth plates. She was from Chicago. She flew in. I repaired her ACL. I told her parents, look, it might not work, it might fail, but they were thinking folks and they said, you know what, we'd rather try. Anyways, now it's 5 years later, she's 17. For the past 5 years, she's been playing hockey and lacrosse and field hockey and all this stuff. And finally, 5 years later, she retore that knee. And now they're coming in to see me from Chicago again. And to me, now her knee is mature. We're not risking the growth plate. She's a more mature woman, right? Or she's a teenager, but she's got much more ability to get through that surgery without the mental and physical scars. And we don't have to worry about her growth plate. So I consider that a success, but in every study in the world, that would be considered a failure because she had to come back. So you have to think about things differently. And let me tell you, if there's anybody who knows that orthopedic surgeons are a stubborn bunch, it's me, because it's hard to convince people to think differently, to even consider what I'm talking about.
How is it going with the other 30 surgeons down for special surgery? How's that going for you?
They will not do it. They will not accept it. And they are none too happy that I'm doing it. Okay. You would think that the Hospital for Special Surgery would be flying my flag way up in the air, saying, hey, we've got an innovation. That's what we're all about. But absolutely not. It is a sore subject here. So it's frustrating, but it is what it is. Look, I'm
Gregory,
happy that we're talking all over the world about this stuff, all over the world. The biggest resistance I have is in my own hospital. It's kind of crazy that way, but you know, I'll talk plainly about it.
Gregory, let me ask you something. You use MRI pulse-up?
You know, I did, and we have looked at some studies. Dr. Ferretti and Monaco in Italy, and we published a paper. My group published a paper showing that it takes a year or two or so for the ligament to turn black again. And everyone is used to saying, oh, look, it's black, that means it's good. But it's different for the repaired ACL because it takes time, because number one, it's alive. You know, the grafts are black because there's no fluid in it because it's dead. But yet the ACL that we repair, there's a lot of remodeling going on. The stitches are in there. And so the ligament looks a little funny, and that can last for up to a couple of years until it settles down. But I base everything off on how it feels and how confident the patient feels in their activities as to whether I think it's loose or not. And I stopped chasing down the follow-up MRIs because the patients are doing well clinically, and that's really all that matters to me.
Okay, there's a really good question here on the chat. You're talking about proximal lesions only, but there are a lot less frequent lesions are the distal lesions. Do you think they also have that repair, that capability?
Yes, I do. Absolutely. And
are you repairing those?
Yep, I have. More times than often than not, at the distal lesion, it comes off with a piece of bone. We all know that. And what we also all know that it's very difficult to get that piece of bone to sit down in its place. That's a frustrating thing. And I will suggest to you that I believe personally that the suture anchors are the way to go for the femoral lesion. It's a very simple technique. It's quick, it's fast, it's reproducible. I think that's the way to go. However, on the distal ones, I think the new fiber ring and tightrope technique that Arthrex put out, I think that's a great way to do it for the distal injuries. I also use that for the PCL and for some other techniques. I've actually repaired torn grafts, if you can believe that. I never talk about that. In fact, this is the first time I've ever mentioned it. So you guys in Colombia, all right, I just went out on a limb and I told you that I have actually repaired about 10 grafts. And if the graft pulls proximally, it always made me wonder, like, why, if we're gonna take the graft out and put more graft in, why can't, if we can retension it and pull it back up, then we can get it to heal. And sure enough, I've got multiple patients who are years out from repairing a graft. And I'm in the midst of like looking up we're looking them up and we're going to get a paper out on that. And that's really going to cause some controversy. They might actually burn my office down.
Okay, but you were telling us 5 minutes ago, those grafts are dead.
Well, no, they're dead in the beginning. They're dead in the beginning.
When do they get alive?
But as they scar in and then they have blood supply. And by the way, it doesn't matter if it's dead because we're going to take out the dead tissue and put in more dead tissue, right?
Oh, that's true. Okay,
right?
That's true.
So really all you're asking from a graft is that it would be scaffolding for the scar tissue to form upon. And my whole thing is if the whole graft is intact and it just pulled up at the top, what's the benefit of putting another graft in when you can simply tension that graft? The thing is that we never had the ability to tension the graft. Now, look, I haven't done enough of these to draw conclusions yet, but somebody's got to be the guy who
starts the conversation.
Yeah, so we can talk about it, right? I'm not saying I'm right. I'm not saying I'm smarter than everybody else. I'm just saying that, look, this is what my experience was. Let's talk about it. And that's why it's so fun to engage with all of you guys. Because trust me, we don't talk about it here at HSS. There's
Greg-
30 people,
Greg-
there's 30 people who says it don't work, and then there's me.
Okay, so
Gregory, let me ask you something. Excuse me, Sebas. No, by your classification, talking about the chairman too, have you repaired this short Brenman in the more distal position? I took this because I did it a few times when I got a short ACL that is impossible to get in
froze.
the AM. Have you did it
Shucks.
before? Está buscando.
no,
Ahí.
creo que dejó de
No, sí.
oírnos.
No, está buscando. Gregory. Que algo pasó porque se congeló. Creo que tenemos, son las 9:21, acabamos a las 9:30, Sebas, si le parece.
Sí, señor.
Y creo que él se desconectó, pero hay unas preguntas que han hecho aquí que me imagino que no, bueno, creo que
Él está buscando porque creo que se le bloqueó otra vez el computador.
sí.
Hay una pregunta que tal vez usted puede contestar, Mosco, y es que le preguntan qué tan habilidoso tiene que ser el cirujano, que si esta es una cirugía para cualquier cirujano o si es para un cirujano muy habilidoso.
No, yo pienso que como todo es primero tener la disposición. Al que hace cirugía de hombro se le facilita porque son técnicas muy similares en reparación de manguito, como él lo mostraba, pero pasar puntos con pinzas automáticas, si lo estamos haciendo con meniscos, imagínense si no lo vamos a poder, si no las personas no lo pueden hacer. O sea, a mí no me
Sorry
parece
about
para
that.
nada.
My
Don't
computer
worry.
crashed.
Yes, don't worry.
You were asking whether
About
I've
Chairman
done it
2.
on type 3s.
Yes, in your classification. How you did it?
Of course I have. Now I've done it on people who, it was either do that or nothing and to see. And so I've got a bunch of folks who've healed type 3s. It's a slightly different technique. I put some stitches in the upper part and the lower part. I explained to them that we're just going to try this and see if it works, and it's low morbidity. I don't talk about it because literally they've tried to kill me just talking about repairing type 1s. So I don't talk about it. I keep to myself, but certainly patients, I've had a lot of patients say, look, doc, go in and see if you can repair it. And if you can't, just leave it and then I'll try conservative. And to me, that doesn't, what do you have to lose? It's very interesting. I've done a lot of repairs on PCLs, on MCLs. I just published a nice article in arthroscopy suggesting that we should do more MCL surgery. LCLs, I used it all the time for around the world. We can do another webinar on repair in the multi-leg setting. It's tremendously effective. That's where I actually started. And then, but on the PCL, what I've found is sometimes people come in with a PCL tear and a big medial meniscus tear. And I said, well, look, we can go in and get the meniscus, and you're going to need to, because you have pain and that's you have a piece that's getting caught. I said, well, while I'm in there, why don't I just repair your PCL? Now, everyone will say, well, you shouldn't do that because most people don't need their PCL. And I said, okay, you're right, if I was going to do a reconstruction. But if I'm going to do a surgery that basically has a similar morbidity to the meniscectomy, well, then why wouldn't I? Right? The downside risk is that your knee is simply as loose as it once was. The upside benefit is that now you have a normal knee. And maybe you won't get arthritis from that chronic posterior laxity. I have a PCL tear, and I would have loved that because I can feel myself getting arthritis in my knee because of the chronic posterior laxity. But look, it's not as easy to do a PCL repair as it is to do an ACL repair. So I would suggest to the surgeons out there, you know, start slowly, learn about what we do, how to do it, practice on the cadavers, practice when you're doing your reconstructions, and don't be a cowboy and just try and go out and do it, or else you're going to find a lot of failures. And then you're going to say, I told you that didn't work. And you're going to be just one of those people. You know, be meticulous about learning about this and how to do it. And then, you know, and pick the patients very carefully. And you're going to find out, just like I did, and just like many, many people across the world have, is that it works. And it's an unbelievably great tool to have in your toolbox. ¿Cómo se dice toolbox?
Caja de herramientas. It's easy.
Good.
Caja de herramientas.
All right. That's
Okay.
not so easy for me. I can't roll my
No. So you told us about your failure rate. It was almost 10% at 10 years post-op. Which risk factors do you think are really important for these failures?
To be honest with you, most of the failures that I've had have been rather significant injuries that probably would have torn the graft. I'll name a few of them because it always shocks me what people do, right? Recently, we had a couple of people playing soccer barefoot in the rain. Now, that's not a very wise idea, right? We've had a few people crash a skateboard. We've had some people skiing. One guy had a car fall on his leg, right? So these aren't, you know, everybody says, oh, see, I told you so. But in reality, these injuries are very significant traumas that people have experienced. And so to me, I was like, well, you probably would have torn the reconstruction. And when you go in to do the revision of an ACL repair, it's like doing an ACL, a primary reconstruction.
Yeah, the first.
It's like doing it for the first time. And every time I've been in, I ask the patients later on about if they knew that they had failed, would they still go back, and if they could go back in time, would they try the repair again? Almost every single patient says, of course, because the reconstruction was utterly miserable. And that's what we got to listen to, you know, because the reconstruction patients are not happy.
Absolutely.
And we all know it in
Julio.
our practices.
What do
They
you,
get there eventually, but they're not happy.
Gregory, what do you think? What are the new trends in ACL repair? What do you think we are going to wear in terms of ACL repair? In your technique, new trends. I mean,
well,
we have to improve in technical. We have to improve in, or that is enough.
Well, let's be realistic. The new trend is actually just getting people to do it. Before we start changing it, let's actually get people to do it and learn to do it well, right? The newest trend is in America is the bear procedure, and that's where
Yes.
they put a collagen sponge in the knee. I have not done that. I've watched someone do that. Some of the, you know, my feeling is I hope the bear works because that will give me a way to address mid-substance tears.
Yes.
Originally, the bear was designed and created and tested to address mid-substance tears. However, a lot of people are simply using it for proximal tears. They were a little nervous to do my technique. And then when the bear came along, they said, oh, I feel better if I put the collagen in there, right? But the trouble with putting the collagen in there is that it's done through a mini open incision, number one. Number two, they're not allowed to fully weight bear until probably 6 weeks. and they're not allowed to go for full range of motion. Actually, they're not allowed to fully weight bear until 8 weeks, and they're not allowed to go for full range of motion until 6 to 8 weeks. And so my patients are running at 6 to 8 weeks. My patients are full weight bearing the day after surgery, unless they've had a meniscus repair. And to me, waiting 2 months on crutches and in a brace, slowly putting, you know, your weight on it and slowly getting your range of motion, to me, that's worse than a reconstruction, right? Because most reconstructions are walking on their leg reasonably quickly unless they had a meniscus repair. So I think there's a lot to learn about it. Like I said, I hope that it does well. I hope that it helps us and gives us another tool in our toolbox. And I'm not going to try and say that in Spanish because it's a very hard word. Muy difícil. But you know, that's one of the major things. A lot of people are hot and heavy about that in America because it just came out and they're pushing it, and so that's given people the ability to try a repair with more confidence.
Yeah, I love this slide when you show the guy that took the graft before, and of course he can never he's gonna do a ACL repair. I love this because, you know, I changed my mind, and I start doing ACL scope, because sometimes I miss something in the MRI, and I thought and this patient needs an ACL reconstruction, but when I get in, the Redman is there, no?
Yeah.
So
amazing,
if you got in your hand the graph, you can do it. Yeah. So
Amen.
that's it.
And you know what I think is, you know, look, I'll go even one further. And there's a lot of people out there who practice what we do who don't even look at the MRI. And I'm going to quietly say, shame on you. All right. And I'm going to strongly encourage them to start looking, because you learn a ton by reading the MRIs yourself. And then you see that the MRI lies. Sometimes it says it's a bad tear and it's actually a good tear. Sometimes it says it's a good tear and it's actually a bad tear. But you never know unless you study your images. So for the people out there who do study their images, I say good job, because that helps us to learn. And for the folks out there who aren't studying their images, I say, come on now. Come on, you know that's important to do. Let's get on the ball.
Okay.
Right?
Yeah, and let me tell you something. We got in Colombia this problem. Not in acute setting, but in chronic setting, that the radiologists read the MRI as a normal ACL, but the patient has instability.
Yeah.
So I know in USA that is very difficult to do a surgery when the MRI say this is normal. How do you resolve this problem?
I say that the patient is has clinical laxity. So even though the MRI is read as normal, you know, I say that on my clinical exam, the patient has obvious laxity, and that many times the ACL is torn off the wall and it's centralized towards the PCL, but it's not doing its job. Those are the easy ones to repair. You just pull them right back to the wall. And if they're stuck to the PCL, you just clip it off. So that's the way I do that. And sometimes I'll say in my note that I do not agree with the radiologist's interpretation, because a lot of the radiologists they just read the report as torn or not torn. Right? And they don't necessarily give you a description of the type of tear, and you know, not all those radiologists do that. And so that we published a paper in the radiology journal telling the radiologist what they need to look for, and when all this was just starting. So that's some more of is stuff there.
Okay. ¿Hay alguna pregunta más, Sebastián?
No, realmente creo que cumplimos con la mayoría de las preguntas del chat.
Okay.
Dr. DiFelice, we want to thank you, so much for your lecture, so much for your time. Your confidence embraces all to think out of the box, I think. Maybe we're going to use this in our caja de herramientas from now on and just start looking around, studying more our images, studying more the anatomy of our cadavers and our labs. We really appreciate the time you took to share with us your knowledge and your experience.
Happy to join you. I think that we are all brothers and sisters in the orthopedic world, and it doesn't matter what country you're from or what language you speak. We're all fighting the same battles for our patients, and this is how it's supposed to be. We're supposed to share the knowledge,
Thank you so much,
Gregory. A Carolina, gracias por acompañarnos. No le hicimos ninguna pregunta a Carolina, solamente el doctor Gregory.
No, claro, ni más faltaba.
Pero muchas gracias
Nice
por
work,
tu tiempo.
Carolina.
Yeah, muchas gracias.
Thank you,
Gregory, I hope to see you in Colombia in 2 years. Okay?
Oh, good. Okay, good. Muchas gracias.
Yeah, you are going to enjoy our country. So thank you so much and see you soon.
Okay.
Have a great night,
Ciao.
doctor.
Good night.
Chao, chao. Gracias,
Goodbye.
gracias. A todos, muchas gracias por el tiempo, para los 66 personas que están todavía con nosotros. Espero que les haya gustado el tema, las conferencias, las respuestas, las preguntas, todo esto. Los invitaremos dentro de un mes a nuestro próximo evento ACCART. Gracias, de nuevo, muchas gracias. Feliz noche. Bye, bye.
Feliz noche, gracias.